honored and fortunate to have with us Dr. David Park. He's an oncologist and hematologist at St Jude Medical Center. He is affiliated also with the University of Southern California School of Medicine, UCLA School of Medicine. He participates, he is participating and has participated in drug trials from both of those that originated in both of those institutions that are available at the Heritage Medical Group at St. Jude Medical Center. He's certified by the American Board of Internal Medicine in oncology and in palliative care. He's also certified by the Board of Physicians and Surgeons in hematology and oncology. And it's a real honor for us to have one of the most outstanding oncologists in Orange County with us here today. So please welcome Dr. David Park.
Thank you. It's a pleasure to be here. I did not time my presentation. I think I have about maybe 20 slides, and I'll try to go through them as best as I can. I think I've been here once before. I can't remember the subject. I think it might have been anemia. And I know that I hope that was helpful, and I believe I ended up having a patient come because of that. Now, that's not the reason I'm here. I'm surprised there's so many people here today. I'm competing with Washington, D.C. I will say words that are difficult to pronounce, but I will not say the words quid pro quo or perfect today. So that's my only political joke. So before we start, I want to play a little video, which I think it's going to sort of, people say a picture paints or says 1,000 words, right? So I think now we have a video that we can take advantage of technology, and it will kind of set the stage of what I would call an introduction to this very, very interesting topic that has changed in many ways. And it's not a perfect thing, it's not the ultimate, but definitely revolutionized the treatment of cancer. And that's the field of immuno-oncology, which when I was training, which is not a long, long time ago, it's just beginning in its infancy. So yes, so I would like to genomics, immuno-oncology, and maybe something else in the future is going to continue to revolutionize our treatment of patients with cancer. So when people talk about immunotherapy or immuno-oncology, there's various understandings of this, and it's a really deep field, and actually I'm certainly not an expert in this. We use a lot of immuno-oncology in the clinic now, and there's a lot of research that has been done over the years. So it's really a visual. If you look up YouTube and you look up T cells, cancer assassin, if you look at it that way on your cell phones, then you'll see this. It's a beautiful video of these T cells real-time attacking cancer cells, and this all color, and you can look it up. I mean, it just makes you understand what immunotherapy is. So we talk about our immune systems fight cancer, and we have a general understanding as a lay public what that means. And we talk about it all the time in our strengthen your immune system, take this, take that. You see this on TV and so forth, nutritional supplements. But when we talk about immunotherapy, especially as it relates to oncology, it's a very specific thing. It's called a T cell. The T cell. So in fact, I would say I would vote for the T cell as the Time Person of the Year in a Time magazine because it's revolutionized literally the way that we treat cancer. The first slide was supposed to be the picture of an Egyptian physician. And his name, I believe, was Imhotep. He lived in the 27th century in Egypt. And if you go back to ancient writings, it appears that we knew that the body can produce something that will kill cancer. So as you know, we knew about cancer since, you're not connected. Yeah, we knew about cancer since the early times, right? So people knew about that, breast cancer, etc. And they knew, and the physicians in Egypt would actually make a cut into the tumor, and there would be an infection, purposely cause an infection, and then somehow the body, this inflammation would make the cancer or tumor regress. So there was a very primitive early understanding of something in our body is actually fighting this cancer the way that we fight, say, a bacteria or virus, an infection, right? So, and it had to do with our response to infection, some sort of inflammation. So, and there's other examples of that through history, even in the Middle Ages, where people thought maybe something like that was happening, but we did not understand clearly what that was, right? What that was, and so until the late 1800s, actually, again, not fully understanding why, but a American sarcoma surgeon, an oncology surgeon by the name of Coley, Dr. Coley, William Coley in New York, he injected a toxin made of from dead bacteria, Streptococcus and Serratia. So he made this cocktail and injected it into tumors, and the tumors would regress. And so there were at least 1,000 examples of this. He and his colleagues in New York were treating cancer that way in the late 1800s. So again, they did not fully understand why, but this was happening. But it was a temporary thing. You know, not very many people were actually getting cured, right? But they're seeing this immune response. It did fall out of favor because that's when radiation came in, right? So radiation, X-rays, radiation in the early 1900s became the new way of treating cancer, and then chemotherapy, right? So we did not understand the mechanism of action. Now, I just want to go over a brief timeline of events. In the 1970s, that's when more and more there was this understanding of our immune system. And one of the first things that were tried, and actually is still used, and in fact our urology colleagues use it, is called BCG. BCG is basically a bovine form of tuberculosis, right? That has been sort of changed so that it's not a very virulent form. In fact, if you go to countries, if you're born in a country, not the US, where tuberculosis is endemic, you may have gotten a vaccine against tuberculosis by using BCG, right? So, and that may have happened here too, many, many, many years ago, right? So we do use BCG, the urologists use it for early bladder cancer. So they will inject a BCG wash in your bladder for non-invasive bladder cancer, and that creates some form of immune reaction inside that actually allows your immune system to kill early bladder cancer. That's non-muscle invasive, non-invasive bladder cancer. So there's definitely examples, even in the 70s, and we still use it, where we are harnessing the power of your immune system, of our immune system, to fight cancer. In the 80s, we started developing and understanding cytokines. Cytokines are basically proteins or things in your body that and there's different kinds of cytokines, there are many cytokines, there's some that stimulate your T cells. So the most well-known cytokine, I don't know if you've heard of the word interferon. Interferon would be a cytokine, and also interleukin-2. So there's many interleukins, IL-2, IL-5, IL-6, IL-10, so interleukin-2. And these two are cytokines that have, that stimulate your immune system, your T cells. In fact, I used to give interferon alpha. I used to give interleukin, and so when I was training. And we use this especially in tumors that we felt that were sensitive to being killed by your own immune system, i.e. melanoma. So melanoma and renal cell carcinoma in the 80s and 90s, there was definitely great data and sometimes long responses, long-term responses to interleukin-2 and sometimes interferon. The problem was, the challenge was, number one, not many people benefited. It was a very small minority of patients that benefited. And number two, it was very toxic to give. It was very, very toxic to give. So as an example, we used to give interferon alpha, high-dose interferon, after resection of a melanoma, stage 3 melanoma, high risk for recurrence. We would give a whole year of interferon. The first month was a higher dose, and then a maintenance dose afterwards. Oh, there you go. So I'll allow this video to play because I think it's a really cool video.
Inside all of us lurks a serial killer. A killer whose primary function is to kill and then kill again. These are cytotoxic T cells, a specialized member of our white blood cells. They patrol our bodies, identifying and destroying virally infected and cancer cells. And they do so with remarkable precision and efficiency. There are about 5 million T cells in a teaspoon of our blood, engaged in the ferocious and unrelenting battle to keep us healthy. These amorphous blobs move around quite rapidly, pushing out their leading edge and probing their environment as they go. When a cytotoxic T cell finds a cancer cell, membrane protrusions rapidly explore the surface of the cell, checking for the telltale signs of cancer. They kill their targets using poisonous proteins visible here in red. These cytotoxic granules move down special pathways in the cell called microtubules to the interface between the T cell and the cancer cell. The T cell punctures the surface of the cancer cell and delivers its deadly cytotoxins. This is very important in our bodies, where cells are packed together, as it focuses the lethal hit on the target and minimizes collateral damage to the neighboring healthy cells. The fate of the cancer cell is sealed. The T cell then moves on, hungry to find another victim.
This is a picture of this Egyptian physician. We talked about Coley's toxin, and we're just going to go through some timeline. So why can't it do it all the time? And I think this is where the big breakthrough came in the 2000, about 10 years ago. This is really, really brand new. And you'll see in the next few slides how the rapid evolution and explosion in this knowledge. So last year actually, the Nobel Prize for physiology or medicine was actually given to in the area of immunotherapy, and it was a dual. Two people got it. One was an American scientist and a Japanese scientist. So and they both worked on immunotherapy, and basically it was given to figure out how certain proteins prevent immune cells, called T cells, which you looked at, from attacking other cells in the body, including cancer, right? So what's the mechanism in which certain proteins and what we call checkpoints don't allow the T cells to actually kill the cancer. And there's a reason for that. There's a reason why we have these checkpoints also, because there's a flip side of immunotherapy or immune system where you've heard probably of autoimmune disease, right? Autoimmune disease. So the way I equate these T cells, I equate them, I don't know if you remember the movie Judge Dredd. The Judge Dredd, Sylvester Stallone. Anyone has watched Judge Dredd? No. Okay, sorry. So he's this, guy that he's basically cop, I guess, jury and executioner, right? He's all of the above. So the T cell, it's kind of like Judge Dredd, where does all of that, recognizes something's wrong, either with your infected cell or some cancer cells, recognizes it, makes a decision, you're a bad guy or you don't belong here, and then kills you, right? Now, Judge Dredd is great if it's right 100% of the time. But if he kind of goes rogue and starts attacking your own healthy cells, that's not good. And that's part of autoimmune disease, when your own T cells now are working against you, right? So your own immune system. So we have examples of autoimmune disease. So there's reasons why the body was created. There's a balance, right? But then now how do we manipulate that balance a little bit to hedge our bets on our favor so we can fight cancer without having too much damage? And it's still a work in progress. We haven't found the final answer of that yet. So these two scientists, Dr. Allison, who is now at the MD Anderson, he did his work at Berkeley. When he looked at a T cell related protein called CTLA4. And there is a antibody, there's another protein called B7, and the B7 and the CTLA4. So CTLA4 is a checkpoint, and then also that is on T cells. And then Dr. Hanjo at Kyoto University in Japan looked at what we call PD-1, a T cell protein called PD-1, programmed cell death protein 1, PD-1. And then you'll hear words like PD-1 and PD-L1. PD-1 and PD-L1 have the most sort of press at this point, and every drug company is making their own PD-1 or PD-L1 antibody, and you'll see that. The CTLA4 was the earliest sort of checkpoint that was developed in drug form, and we have one example of that, at least in the market right now. So again, this is just a quick overview. You saw the picture what happens where some sort of infected cell meets the T cell, and the T cell recognizes it as bad, either deficient, infected, or cancer, and tries to kill it. The T cell and what we call a cytotoxic T cell. So I'm sure you heard about T cells because in the HIV/AIDS epidemic, people used to talk about their CD4 count, right? CD4 count. Those are the helper cells, right? Those are the CD4 is a different kind of T cell. We're talking about the CD8 T cells, cytotoxic T cells, and then there's something related called natural killer cell, which there's probably more to know in that. But again, you could see PD-L1 on one side and CTLA4. These are the two checkpoints that we are trying to manipulate by doing antibodies. You see that antibody anti-PD or anti-CTLA4. And the purpose of this is these are checkpoints that don't allow the T cell to either recognize or to get activated. So what you're trying to do is you're trying to get in the way of that checkpoint. So that's why it's called checkpoint inhibitor. Checkpoint inhibitor. And now the T cell is free to recognize these tumor cells and kill them, right? So that's the theory, and has worked wonders in many patients. Not all, but in many patients so far. It has revolutionized the way we treat cancer. That's not the whole story, but that's a huge, huge, huge improvement. Cancer is not simple. This is, as you can see, this is just a little picture of the many different pathways in which cancer cells survive. And our cells are not very simple. our cells, the way God made our cells, did not make it very simple. So that's just part of the story, but it's a big part of the story, right? So again, this is just another way to simplify things where there's so many different ways that you can actually intervene and attack and stop the growth of cancer. And in the pink, on the pink in the, right there, in the pink square, that's immune activating anti-CTLA-4. So that's one of the ways that we would fight cancer, but there's other pathways. So we're using all of them. We're using all of them appropriately as needed. So again, now going back to just the practical things, and these are the things that you may hear about. So one of the first, essentially the first checkpoint inhibitor approved. It's easier to always to say the brand name, which is Yervoy, rather than ipilimumab, right? Ipilimumab. So you'll notice that a lot of these names, especially the generic names, will have an A, B at the end. Letter A, letter B, which is antibody, right? Ipilimumab, tremelimumab, pembrolizumab, there's a lot of mAbs in there, right? So it was approved for metastatic melanoma, metastatic renal cell carcinoma more recently, in combination with a PD-1 antibody. So we're using either by itself or together. Ipilimumab is not used as much, but we are using in combination. But by itself, it used to be used in the past. It was even approved in the adjuvant melanoma setting, but is not used as much because it's fairly toxic. It was our first foray into immunotherapy. So there's added toxicity, but value also. So we still use it in cases that are indicated. So ipilimumab was the first in 2011. So you can see this is pretty new. FDA approval 2011, that's 8 years ago, right? There's another CTLA-4 antibody that is in clinical trials, tremelimumab, and that's actually, we actually have a trial open at St Jude for bladder cancer, metastatic first-line bladder cancer, where they're using this plus another checkpoint inhibitor by the same company and in combination with chemo. So now we're trying to combine these things, right? So we have that trial open at St Jude as an example. And that's something that we're doing together with UCLA. So now, most of the things that you hear either on TV commercials, etc. I don't know how many of you have heard or seen a commercial on Keytruda, right? Hands are going up, right? Keytruda. I think that's the one that is out there the most, right? So 2014, Keytruda, and then you'll see generally a patient with lung cancer, right? Lung cancer patient usually is a gentleman who's fixing cars with his family, and that person has stage 4 lung cancer. And you would think, oh my goodness, the average life expectancy of stage 4 lung cancer before immunotherapy was about 12 months. We're adding more chemotherapy, something else, and then we would advance it a month or two. And then most people did not live beyond 24 months at most. So with Keytruda, and this does not apply for all of them, either in combination with chemotherapy or by itself, and there's certain criteria, and it's kind of complicated to explain here, but sometimes you can use Keytruda or pembrolizumab. I'm not supposed to use the brand name so much, but it's easier to pronounce Keytruda. But pembrolizumab by itself, you can use it, or you can use it in combination with chemotherapy. We just had the latest data sort of update from the early phase trials that started over 5 years ago, And there was at least, I want to say maybe 30% 5-year survival, meaning that 30% of people on that trial were alive more than 5 years with stage 4 lung cancer. And that's a huge change. And many of them with quality of life that is excellent, because immunotherapy, as you know, works differently. It's not a free lunch, but it works differently than chemotherapy. And many of them actually are not on therapy anymore, because after a few years of treatment, and we don't really know exactly the timeline, we know that definitely 2 years is better than 1, but we don't know if we should go beyond 2 years or not. And then we're talking about single agent pembrolizumab here. The T cells start learning, and they teach their progeny how to fight the cancer. So there's some sort of a residual effect after, right? So many times, in fact, a lot of the FDA labels now say use it for 2 years and then stop and see what happens. See what happens. And if they grow back, then retreat again, right? So as you can see, all these either PD-1 antibody or PD-L1 antibody, you can see the action is literally the last 5 years. 2014, 2014, 2018, 2016, 2017, 2017. So these are all different drug companies making their own version of a PD-L1 or PD-1 checkpoint inhibitor. Things are moving at a dizzying pace. We see amazing results in some patients, not all of them. In fact, I have one patient I'm going to see in clinic today who had a big size, almost between a golf ball and a tennis ball size, big mass of skin cancer that had relapsed. Surgeon said, we can't take it out right now. It's something that if you make it smaller, maybe we'll do it, maybe radiation, right? So there's an agent called, the third agent from the top, Semiplimab or Libtayo, that was just approved last year for this particular indication. After 3 sessions, and it's given about every 2 to 3 weeks depending on what you use, after 3 sessions, the thing, I can't even feel it. He actually showed me a piece of flesh that fell out. He actually took a picture because as it was healing and dying off, some skin kind of fell to the ground, and he thought that he was supposed to pick it up and put it back on again because it was so dramatic. He didn't know what to do with it. So he took a picture of it. Obviously, he threw it away. You can't even feel what's going on there. There's those cases, right? I have patients who with metastatic melanoma who are working full time, whose whole body was just riddled with melanoma 4 years ago, and they're working full time. I have a young 35-year-old patient like that. Those are just anecdotal stories. We have plenty of those. It does not work for everyone. There are some patients that it just does not work. And we kind of understand, but we don't. There's some things that we do. There's basic testing on the tumor, some assays, PD-L1 stains, depending on expression. We can maybe predict. There's other things that are a little bit more sophisticated, what we call tumor mutational burden. But we still haven't figured out, is it the tumor? Is it the microenvironment? Is there a ratio between the tumor and the normal microenvironment? It's still in progress. But we have in some things we can tell, in other cancers, and not every cancer is the same. So it's a moving target right now. It's a moving target. So, and let me give you the indications. Look at that. Each drug may have 2 or 3 indications. So now we have this wealth of PD-1, PD-L1 antibodies. We have all these indications at different stages. Doesn't apply to everybody and every indication at all times. And so the FDA now is saying, you know what? Drug companies, stop making another Me Too drug, right? Let's go to the next level now. We have plenty of PD-1, PD-L1 antibodies. We have 6, 7, there's a Chinese company that is making Beijing, their own PD-1. Everyone wants to do this. Let's move on to the next. Let's do combinations. Let's try to figure out how to use these better. Plus, let's go to the next level. We're at this bottleneck right now. I was at a meeting about a few months ago, and it was organized by this company, and the FDA commissioner was there, not the FDA commissioner, the chief of the FDA Pasteur, who's the oncology chief, was there giving a speech. Actually, I got to meet Dr. Gallo. I don't know if you know Dr. Gallo is a co-discoverer of the HIV virus, right? He was there, and people are talking about, okay, we have all this great news, great success, this is amazing, but what's the next step? So where do we go from here? NK cells, oncolytic viruses, etc., right? But the one thing that I do want to point out is that for the first time, and if you look at the last one, I bolded it, MSI high, that's microsatellite instability. Microsatellite instability, which means in layman's terms, where basically the genetic variation in your, as a tumor, as a cancer, and this is more related to the cancer, there's genetic changes that happen, and it's an unstable form, and that's kind of what cancer does. But there's a specific measurement of instability that we look at the cancer cells, and there's sophisticated tests that we do, and we essentially do it on everybody that has metastatic cancer now, because if your microsatellite instability is high, if your microsatellite unstable, then you have a very high chance of responding to checkpoint inhibitors like Keytruda or any other. Actually, Keytruda is really the only one, plus there's another one that is approved for a certain indication, but Keytruda had this broad, pembrolizumab, broad indication. They don't even care where it came from, what cancer. It's what we call tissue of origin agnostic. So it could be lung cancer, colon cancer, bladder cancer, it could be melanoma, or it could be cervical cancer, you name it. If it's microsatellite unstable, the FDA has said you can use pembrolizumab because there is a high chance that you will respond. So now we're testing this on literally everybody that comes with advanced cancer. So, and we do what's called a broad molecular profiling, which is another topic. So, there's no free lunch, right? There's no free lunch. Only kids think that there's free lunch, right? Once you're in the real world, there's no free lunch. And there are side effects of this. And it has to do with that other side of that coin that we talked about, right? Judge Dredd, right? That when it goes rogue and it starts attacking your own body, and you start having what we call adverse immune-related events, right? So any sort of itis, when you get arthritis, right? That's inflammation. So you get pneumonitis, lung inflammation, potentially hepatitis, myocarditis, which can be serious and fatal and super rare. It is super rare, but it can be fatal. Myositis, muscle aches, colitis, diarrhea, which it can manifest in diarrhea. So we ask patients, you gotta call me. If you have diarrhea, don't ignore it. You gotta call me. You gotta call me, because there's ways that we can treat that, and sometimes we have to treat it urgently, right? If you're short of breath, start coughing, you gotta call me. This is not something that wait 3 weeks and I'm gonna find out. No, I need to know the next day, right? The next day, and so there's protocols on how to manage these endocrinopathies. Patient can get insulin-dependent type 1 diabetes, and sometimes it can be permanent, right? So renal failure. We had one patient in our practice that ended up getting renal failure and dialysis for a while, right? Also, if you do have a history of autoimmune disease, Crohn's disease, rheumatoid arthritis, if it's active and it's, you're really struggling with that, then this may not be the right thing, because it may make that worse. The T cell, we can't really, as of today, finesse it to the point where only attacks cancer cells and not your body. We just don't know how to do that yet. But even if you have quiescent autoimmune disease, meaning that your rheumatoid arthritis is very well controlled, Crohn's disease, once you use this, there's still a chance, maybe a third, that it may cause a flare. Sometimes we have to take that chance, right? Because we're talking about advanced cancer. So we have to take that chance. And then there's these annoying but not super serious things, and we don't really know exactly why, but probably has to do with the immune system, fatigue, some sort of rash, joint aches, muscle weakness, dry eyes, change in appetite. So there's these other things that can happen that people will put up with, and they'll say, okay, just give me a little steroid cream, some Tylenol, and so forth, as long as my cancer is under control. Now, sometimes the cancer will be completely gone. We can't see it on scans. Doesn't mean that it's gone. Sometimes we see it there, shrunken, and we just don't see it move. So I need to do a time check. I think I'm almost out of time. I just briefly want to go to the next few things. Now, what is the next, another form of immunotherapy that you may have heard about is CAR T. You may have heard of CAR T cells. Now, this is not CAR T. This is the beginnings of it, where now what you're doing is, and this is actually approved for prostate cancer. It's not the best drug for prostate cancer. Remember, it's 2010, which for us now is ancient history in the era of immunotherapy, where now what you're doing is you're taking cells from your own body, and this is patients with prostate cancer. You send it out, and you are attaching making it learn, attach a prostate cancer protein, a generic protein, cause an immune reaction. This is all done in the lab. So if you look at the picture, you collect the cells for a few days, and then you bring it back and you inject it back into the patient. And now this thing will stimulate your own immune cells to fight the prostate cancer. And it is FDA approved. It wasn't an amazing change, but it was an improvement. It was an improvement. Now we'll go to what's called chimeric antigen receptor cell therapy, or CAR T. So you'll hear a lot about CAR T. You haven't heard much because these are given in specialized institutions like our colleagues at the City of Hope, USC or UCLA, because there is a lot of toxicity involved and also a lot of cost. Each CAR T therapy is about $300,000 to $400,000, right? So, but this is the next generation. You are genetically re-engineering your own T cells and giving it an artificial T cell receptor and then injecting back into your body. So what happens is you go and you remove blood again. And this is not just a little blood draw that you do in the lab. It's called you get an IV and then they leukophorese. And then you send it out to the lab. They manipulate it genetically, your T cells. These are your own T cells, very personalized, right? And then they make it grow. And so it takes time. So the question, the challenge is, how do you make it not take 20 days or 17 days while you just wait now for these CAR T, right? And then you inject it back. And it's amazing. We have patients who have refractory leukemia, lymphoma, who are having long-term remissions. Not everybody again, but long-term remissions. So there's 2 that have been approved 2 years ago, and there's probably more in the coming and changes. Again, only available in specialized institutions because there is a lot of side effects associated with it, cytokine release syndrome. In fact, once you get this treatment, you're supposed to be within a certain driving distance from wherever you got it for almost a month, I think. And then because anytime this badness can happen, you have to be in the ICU, or and people are learning how to use it, right? There's a learning curve. So, and the cost is fairly, it's $300,000 to $400,000. Now, there's also CAR T research being done in solid tumors. It's still not there yet. It's more for leukemia, lymphoma because of the receptors that they studied in. In fact, the only patient of mine that did receive CAR T at City of Hope was a patient with brain cancer. Unfortunately, it didn't work for her. So they're still working into this, breast, prostate, colon, and brain cancer. There's active research going on. And again, So I want to end with the fact that we at St. Jude, we do try to bring this into the community, which is essentially 5-6 minutes away from here. So we have immunotherapy trials in lung. In fact, we were one of the first in Orange County that got that pembrolizumab, the Keytruda. We had that pivotal trial open St. Jude years ago, and that trial led to the approval of that drug on certain patients with lung cancer stage 4. So that was our collaboration with UCLA. So we have other trials with bladder, I mentioned earlier, urothelial cancer, breast, esophageal, prostate, and kidney. So it is very exciting. I'll take a few questions. We're just, moving along. Yeah, so those are very, very good questions. First of all, the more common side effects are the minor side effects. We talked about the fatigue, the rash, those are the most common side effects. And in fact, there's some theory, that's not theory, observation that having some actually may be a sign that it's actually working. Yeah, having some, what we call adverse immunotherapy-related events. Now, the more serious ones are the colitis, the pneumonitis. Generally, they respond very, very well to steroids. So we give steroids because what do steroids do? They kill T cells, right? They kill T cells. So there's an interplay here. You don't want to be on steroids while you're on this, at least not too much. So there's some, wiggle room there that we do. And also, once you have stimulated the T cells, they've learned it, and they're going after cells and they're expanded, having some steroids doesn't really actually negate what already happened. So it's okay. So it's not like, oh no, I don't want any steroids. No, you have to have them if you have to have them. And they respond very, very well. And there's a way to manage these. They usually get better within days sometimes. Once you start, a good amount of steroids, and then you sort of taper slowly over time, because if you taper too fast, then it can flare back again. So, but as far as the diarrhea and the more serious adverse events, it happens. I mean, I can't tell you exactly the number of, we do see it all the time. I mean, we give steroids, sometimes we give a short little burst of steroids, sometimes we get a whole month of steroids. Some patients have to be hospitalized to get steroids. And then if there's other things besides steroids that we do. So communication is key. So we always tell patients who are on immunotherapy, who start immunotherapy, you know what, I don't, just call us with anything for now, until you kind of get the hang of it. Yes, what about infection? What about infection with immunotherapy? So that's the thing about immunotherapy, it's not like chemotherapy. It doesn't really kill your white cells, depress it. Now there are rare side effects of immunotherapy where autoimmune bone marrow suppression can happen, but it's super rare. We rarely see that, but we're not as at risk for infection the way that, when you get chemotherapy. So that's a great question. Yes?
How does it differ from stem cell therapy?
Stem cell therapy. So it's different in a sense. So I don't know what you mean by stem cell therapy. Okay, so there's stem cell therapy has a huge, and you'll have a stem cell expert coming from UCI, I think you mentioned. So I don't know exactly. So I'll tell you where stem cell therapy is used right now in oncology for us. Okay, so I'll just limit it at that, because stem cell therapy, it can be really complicated. You can talk about gene editing therapy for like sickle cell, and there's many different things now. I mean, crazy stuff is happening. We're putting in and editing genes, etc. But
multiple myeloma.
yes, okay, so that's better. Yeah, that's more specific. So stem cell therapy. What do we mean by stem cell therapy? Multiple myeloma. So multiple myeloma is an incurable disease as of today, right? So there's a little bit of controversy, but most people agree that on a patient that can tolerate what we call auto stem cell transplant should get what we call auto stem cell transplant, which what is the following. You get an initial regimen of what we call induction treatment to lower as much as possible the myeloma levels in your system, including your bone marrow, right? So you go through a period of induction. Generally, it's about 12 weeks or so. And then you get the maximum benefit. You clear the marrow as much as you can. And what you do is you start collecting your own stem cells, So we don't call it bone marrow transplant anymore. I mean, we say that, but it's really a stem cell transplant. And there's a way to collect them by stimulating your stem cells. We have medicines that we can give that make the stem cells come out of the bone marrow into the peripheral blood. You can actually collect it, kind of like you donate blood in the same way, right? You collect it. And then you make the patient go through some other sort of a preparation chemotherapy to, again, kill as much as possible all the myeloma, and you rescue them with your own stem cell, right? So your own stem cell finds its way through and goes to the bone marrow, and that seems to give you the longest remission. But things are changing. That may not be necessary in 5-10 years. We may have such great myeloma medications that stem cell therapy may not. In fact, there's one expert in LA, one of the leading experts in myeloma, who does not believe in stem cell therapy for myeloma patients. So, and it's a little bit of a debate there, but we do recommend at least a consideration and let the centers that do stem cell treatment, transplant, like City of Hope, USC, UCLA, or Cedars, those are the only ones in Southern California that do it as of today, to consider the patient for that and let them decide and the pros and cons, because it's not an easy treatment either. It's easier definitely than allo transplant, which is getting your stem cells from someone else, like your sibling, right? This is an auto transplant. Yeah. The question is, with the rapid growth of cancer cells, so we always tell patients, hey, cancer cells, they don't like dying, you know? They want to survive too. So they constantly are trying to grow, they mutate, they change, right, to survive. So, and this is where chemotherapy, there's some limitations to chemotherapy because they start figuring out, okay, you know what, I'm gonna break the code on chemotherapy. You're attacking me with the same drug, I'm gonna break the code and try to resist it. So they develop these multi-drug resistance, kind of like antibiotics and bacteria, right? They try to do this. They're smart. I mean, they're not smart here, but they just, what they do is they have a lot of opportunities. So it's kind of like cracking your password. The more you try, eventually they'll crack your password, right? So that's what cancer cells do. Immunotherapy is different in a sense where it's not depending on any sort of inside mechanism of your cancer to kill it. So it's not depending on DNA replication, you know, and fooling around with their DNA replication is not interfering with their sort of a protein translation, right? What it's doing is just recognizing the thing and eating it up. You saw that, right? It's just, you know, recognize it. But remember, the checkpoint. These cancer cells have these checkpoints to protect themselves. So that's why people develop cancer, because these T cells were not recognizing these cancer cells as bad, right? And this is why the Nobel Prize was given to these two folks that, hey, let's take away those brakes and let's make a drug that is inhibiting those checkpoints. That's why it's called a checkpoint inhibitor. And now you remove those brakes, and now the T cells are like, it's like the blinders are off, you know, and they're like, wow, you know, there's this guy, there's that guy. But what's the mechanism of resistance? We don't know. I mean, there's other checkpoints. We just know these two that we just talked about. There's IDEO. There's other ones that are being studied with some success. I'll be honest with you. There's some immunotherapy. There's some cancers that have not been very successful. We have not been successful. We just got updated recently a trial, pancreas cancer. You know, it's just tough. You know, we just tried immunotherapy on them, and there was a combination treatment that was essentially a negative trial. Certain types of colon cancer. So the colon cancer that responds is the one that has the microsatellite instability. In fact, one of my patients was featured, I think, on the St Jude Health Matters magazine, because he was one of the first ones to get pembrolizumab even before the FDA approval. And he had MSI high. And and I just gave it to him because we had gone through all the chemo. The guy's coaching his kids' baseball team. I mean, he looks like he doesn't have cancer, and it's now, I think, 3+ years. I mean, he was on his last chemotherapy, and we got this even before the FDA approval. One last question, because I do start clinic at 10:30 today.
I was wondering about, you mentioned steroids being destructive to T cells.
Correct.
Yes. I know now why they're so reticent. I did not know that about the steroids and why they're...
Yeah, so like the steroids being destructive to T cells, but I don't want you to take home the message that we should never use steroids either. Every drug has its purpose and its role. There's no smart drugs or dumb drugs. There's smart doctors and smarter doctors. So you have to listen to your physician, to your provider, right? There's a reason why they do certain things. There's a reason why they're limited. There's a reason why we talk about it. We talk about the pros and cons. It's just sometimes we have to use it, and it's good. It's a great drug for many different things. We just have to know how to use it and when to use it.